for the work session on the MOA 2017 health plan renewal. And let's start this time doing
Amy Kambowski.
Pete Peterson.
Joel Evans.
Elby Gray Johnson.
Dick Train.
Forrest Dunbar.
Tim Steele.
Ethan Berkowitz.
Jennifer Bundy Cobb.
Julia Petty.
Mike Abbott.
And around the room in the audience, please.
Bill Palsy.
Suzanne Flukery.
Sherry Easley. Sheree Hendricks. Karen Turner.
Lance Welber.
Joanne English, employee relations.
Barbara Jones, municipal clerk.
Chris Schutte, having lunch.
Thank you. Mr. Mayor, you have the floor.
Thanks very much, Madam Chair. I just wanted a couple of quick introductory remarks, and I'll turn it over to the professionals here. The healthcare represents the second largest item in our budget in terms of what we pay out. It's approximately order of magnitude $75 million out of a roughly $500 million budget. It's about 15%. And that has sort of been consistent over time, but we've got to bend that curve. And I think understanding where that money's going, some of the trends that are existing might help the assembly, help the administration when it comes time to enacting some of the reforms that I think will be necessary moving ahead. So that being said, we should probably jump into the work session. Julia?
Thanks for having us today. I hope you'll find this informative. And as we go along, if you have questions, please don't hesitate to ask. So on the agenda today, we're going to talk about self-insurance, what our 603 fund is, stop-loss insurance. I'm going to give you some of these terms. Third-party administrator. We're then going to go into the plan performance of 2016 and talk about our renewal for 2017, how we got there, what benefit plan recommendations, and then looking to the future. So, the municipality of Anchorage is self-insured, and this means that that the MOA assumes the financial risk for providing health care benefits to our employees and their dependents. Self-insuring exposes the municipality to larger risks in the event that more claims than expected are paid. We have stop-loss insurance, and that's an insurance product that provides protection against catastrophic or unpredictable losses. The MOA specific stop loss is $500,000. This means that when an individual's claims exceed $500,000, the stop loss carrier, currently it's LifeWise, which is a subsidiary of Premier Blue Cross Blue Shield of Alaska, becomes liable for those eligible losses. As a self-insured plan, Premier Blue Cross Blue Shield of Alaska is our third-party administrator. So claims are submitted to Primera from the provider. Primera pays the provider. They also send an explanation of benefits to the member, and then we reimburse or pay Primera on a weekly basis to cover those claims that they've paid on our behalf. You'll see a term up there, the 603 fund. That's our internal fund. We call it, that's actually the number is 603. It's funded by the municipality's contributions, and they're allocated to each department. There are outside sources of funding as well, and they come from COBRA premiums for those terminated employees who continue on the health plan, the Police and Fire Medical Trust, and Gentilly funding, any insurance recoveries, and flexible spending account refunds. The effects on the 603 fund are things like claims for all the health benefits, so medical, dental, vision, audio, third-party administrative fees, consultants fees, stop-loss administration fee, and portions of the benefits staff salaries also are allocated to the 603 fund. On this particular slide, we're talking about our claims experience. If we look to the upper left-hand corner, in 2014, we ended the year with an 89.8% loss ratio, which is excellent. So we came in almost 11% less than we had predicted, so that's great. In 2015, we ended the year at 108.2% loss ratio. It was a bad year. So far in 2016, we're projecting that the loss ratio will end the year at 113%. So again, not a great year. And the graph to your right shows you the funding versus expenses and of the per person premium or per employee per month premium. And you'll see in 2014 our funding was higher than our expenses. In 2015, you can see the graph on the chart on the left, the funding was less than our expenses, and we're seeing that same trend for 2016, January through July.
Can you explain a little bit fire?
Oh, sure. And one thing that played a large effect on our performance in 2015, in the fourth quarter, the fire department, or the IFF, left the municipality's health plan January 1, and their utilization went through the roof. It almost doubled from what they had previously. So they found out we were moving to Primera, or they were leaving the plan, and they had a very significant utilization.
So just clarifying, when Juna said that all municipal employees are in this plan, all the municipal employees that are in our self-insurance program are in this plan. Several unions have their own health insurance programs. We make contributions on behalf of those employees to those programs, and those programs are independently managed. IAFF had been a part of the Muni's self-insurance program for the last 11 years since we've been self-insured, but they opted out as their collective bargaining agreement allowed for, effective January 1st. So the dynamic, which had been pretty static about which unions were in our plan and which unions were out, changed in 2016 for the first time in quite a while. So that's why we're talking about IAFF leaving. There's several other of our unions that are not a part of this program as well. So.
Thank you, Mr. Abbott. I'm going to go to Ms. Evans, but I have a follow-up question. So, Ms. Penny, you said that at IAFF, their costs went through the roof, evidently before they left.
Right,
Okay.
when they notified the municipality October 1st of last year that they were terminating, they were leaving the MOA plan, going to their own plan. And we saw, not just with IAFF, but it's inherent nature that when it's kind of the devil, you know. So we were with MODA, had been for a number of years. People knew them, knew how they paid claims, what their networks were, etc. So there was a lot of usage across the municipality, but IAFF's was much, much greater.
Okay, thank you. Mr. Evans?
Thank you, Madam Chair. I think that may have clarified some of the confusion I was having. For the unions that opt out and have their own plan, you indicated we make a contribution. Is that contribution a set amount, or does it vary if they have greater experience in their plan?
No, we make a contribution that is determined in the collective bargaining agreement. And then that goes into typically a trust that's operated typically by those unions themselves. And we have no control over what their plan looks like, how much the employees contribute to their premium, or any of that. That is all based on, so our maximum exposure is the monthly contribution rate, and that is what is bargained for in the CBA.
And thus, so for those unions, their usage is not going, we'll know in advance they won't cause.
Doesn't matter, we don't know, we don't care, we don't have any liability for higher usage, or we don't get the benefit of lower usage.
Gotcha. Thank you.
Thank you, Mr. Evans. Mr. Trainee?
Mr. Abbott, is there a different dollar amount than per union to pay for employees?
Yep.
Can you give us a chart that just shows us by union?
Yep.
What we pay?
Yep.
per employee.
Mhm.
Thank you,
Thank you,
Mr.
Mr.
Training. Ms. Penny, please, continue.
So I think we can go on to the next slide now, unless there are any other questions.
Not at this point, thank you.
In addition to high utilization in 2015, we also had a higher percentage of large claimants. This graph shows us in not only a pie chart, but also in a table where those large claims fall. So if you look at the very first line, you see large claims in our definition is anything over $100,000. So for instance, in 14, 7% of all of our claims were in that 100,000 to 125,000, 5% and 5% in 15 and 16. Then we go down to the next to the bottom row in the table, and claims for patients over 500,000 in 14 was just 2% of the total claims amount, 7% in 15, and in 16 to date, we're at 13% already. So we have some significant large claimants.
Mr. Training.
Ma'am, can we get a copy of that slide, because it's not in the packet?
Oh, it isn't?
No. We're looking for it, and we don't see it here.
Oh, I apologize for that.
I think it's
Thank
gonna be
you.
a two-sided thing, we're gonna get every other
I was
page.
gonna say.
Mr. Dunbar?
Can I ask a question on that? Thank you, Madam Chair. So do we track, or do you have anything you can share with us that says, so the 13%, this sort of very significant increase in these very expensive claims, do we know if that is because there are more people with particular kind of expensive treatment, or if a certain kind of treatment has become much more expensive? So I'm just thinking in my mind about the massive increase in the price of the EpiPen, for example, that recently happened. And do those kind of changes, or let's say the consolidation of a medical office in Anchorage that led to much higher charges of a certain type, does that drive that percentage increase, or do you think it's just more people of a certain?
Well, the cost of healthcare in Alaska does trend upward every year. So it's both. It's higher utilization and it's the cost of care.
Are you able to break that out? So for example, if you could say, we have 40 of these people, but 5 years ago, 20 of them wouldn't have been over 500,000, but for the increase in healthcare costs.
And let me introduce another member of our team today. Jennifer Bundy Cobb is with the Wilson Agency, who is our benefits consultant. They've been working for the Muni for a number of years, and we rely on Jennifer for answers to questions just like this. So Jennifer, why don't you describe for the members what sort of data we're able to provide?
Short answer to your question is we could provide that sort of data, not at my fingertips, but we could. The answer to, I think, to pick up on where Jenna left off, particularly in 2015, there were several members of the health plan that had claims in excess of $2 million, and that hasn't happened historically as much. Maybe there was one every couple of years, and in 2015 there were more than we've seen in the past.
It's a flat swan.
Thank you. Mr. Dunbar, you have another question?
I guess without violating HIPAA or any other kind of privacy, can you tell us what these black swans are?
Well, I could. I don't know the names. Jen,
No,
Jen,
I don't want
know
the
the
names,
but
but
I'm somewhat concerned to start sharing diagnosis in a public setting, because it could be tracked down to individual people.
Sure.
So I would want to probably handle that in a different way.
Thank you, Mr. Dunbar. Mr. Weddleton?
Thanks. I just got a question. So the percent of membership, bottom row, the numbers look, I don't understand it, or that far right corner numbers. Is that how many people take advantage of it?
So less than 1% in 2014, and so far in 2016, less than 1% of your membership are accounting for the large claims that are being represented on the chart, and in 2015 it was just over 1% of your membership.
So we went down to 0.09, we're up to 30 million. Isn't that right?
you're reading it right, and I would need to double check the math to be sure that that is accurate, but that is how the chart reads.
Thank you, Mr. Robinson. Mr. Steele, did I see your hand? up? You
No.
just waved. Okay, Mr. Peterson.
Thank you, Madam Chair. And so, do you think the higher number of large claims has something to do with our aging workforce, or is this just sort of a luck of the draw type of thing?
In 2015, I will tell you it was a luck of the draw situation. Again, based on what I do know of the diagnosis and the members of, and the claimants in question, and again, without getting into too much more detail, because you might start to speculate who those people were, it was a luck of the draw.
Okay, thank you.
Thank you, Mr. Peterson. Ms. Penny, please continue.
We are, with our renewal this year, we are anticipating making some plan design changes which will help decrease the rate of increase that we're expecting for next year. And I just wanted to point out just at a very high level what some of those changes are that we're proposing. So right now we have 3 different health insurance options. One is a $500 deductible plan. We have a $1,000 deductible plan. And then we have a qualifying high deductible health plan that has either an HSA or an FSA attached to it. And for the 500 plan, currently the individual out-of-pocket maximum is $2,000, and we are proposing to go to $3,000. In the $1,000, it would be a $2,000 to a $3,500 per member. The health savings account, the individual deductible or out-of-pocket maximum is $5,000, and we're proposing for a family to go to $13,700, and that would be the family out-of-pocket maximum for all 3 of the plans. We're also proposing some changes in the prescription drug arena, and those you can see we're proposing to move to a $10 generic, a $30 preferred brand, and non-preferred brand 50% up to $150, and then for specialty pharmacy 50% up to $150 as well. We're also proposing a change to the out-of-network reimbursement. You may be aware currently in the state of Alaska for fully insured plans, there's a regulation that requires non-preferred providers or non-contracted providers, another term, are reimbursed at the 80th percentile of charges in a geographic area. We're proposing to because we're self-insured, we can basically design our own plan. And we are proposing to change that 80th percentile to 125% of Medicare for all 3 of the plans.
I have a question. Are the plans 80-20?
Yes, in network's 80-20, out of network is 60-40.
Okay, thank you.
And that would not change.
Thank you. Please continue.
Any other questions on the proposed?
Mr. Wellington?
So that 80% thing that the state said, we don't have to follow that.
Correct.
But we
Because
have
we're-
been, but we don't have to.
Right, we have been, but we don't have to because we are self-insured.
Thank you, Mr. Wellington. Mr. Spears?
So these terms aren't negotiated, or are,
With the unions?
yeah.
No, sir, they are not.
We have an
So
advisory
it's what we're
process.
offering.
We have an advisory process where we present proposed plan changes to representatives of the bargaining units, and we have an opportunity for folks to comment on the proposed plan changes. That conversation is underway. We presented it to the benefits committee earlier this week, last week. And so, yeah, earlier this week. And so we may well get comments from the bargaining units through that process. But ultimately, the plan design choice is the municipalities.
Thank you, Mr. Steele. Mr. Dunbar?
So I had heard stories, and perhaps they're apocryphal, from other insurers that in some cases it was cheaper to fly people to Seattle, have procedures done there, and then fly them back and incentivize employees to do that. Is that something that we do?
Yes.
How often do we do that, and sort of what kind of patients do we do that for?
Premier has, currently, there are 80-some procedures, I believe. I think it's 80. It started out at 17 when we first joined Premier in January. It started at 17 different procedures where they would help make your appointments, fly you down, etc. And that has now increased to, I believe it's 83 different procedures. And it isn't just to Seattle. If you had family in Missouri and felt that you wanted to rehabilitate there, and because you had family help, then they would fly you to Missouri. You could have your procedures, and then they'll fly you home. And they actually, it's up to the IRS allowables that they do, that's possible, at least for the, if you have, not travel expenses, but hotel, meals, things like that. So and that is part of the plan that we have with Premier.
Do you, I mean, and this might be a level of granularity you're not prepared to, but do you know approximately how many of our employees do that per year, or appear to be doing that this year?
It's been very limited. I don't have a specific number for you, but it's been very, very limited because it's new. You know, it's new and different.
Thank you, Mr. Dunbar.
We'll be actively promoting that, and Primera will be as well. There are some procedures where the savings are just silly. Even if you include a robust travel increment, it is still a whopping savings for the program without any diminution in care.
Thank you, Mr. Abbott.
Thank you.
Mr. Trainee?
Mr. Abbott, how long are they flown down for? Is it a thing where they fly down these procedures?
Totally depends on the
Do we
procedure.
store them down there for a couple of days?
Totally depends on the procedure. And it's essentially, it's done on a case-by-case basis between Primera on our behalf and the patient, the employee and the patient. And anything that makes sense, Primera is authorized to do.
Thank you, Mr. Trainee. Mr. Steele, and then Mr. Peterson.
I'm fine.
Thank you, Mr. Peterson.
Thank you, Madam Chair. And, you know, I hear stories of people in the lower 48 flying to foreign countries to have operations done. We aren't doing that at this point, are we?
No international travel is a part of our plan.
Okay, great. Thank you.
Thank you, Mr. Peterson. Mr. Wellington.
So this expects about 1.4 million in savings. Is this a zero sum? Like the municipality saves, but the workforce pays that much more? Or is it, how much more will this cost?
It's a diminution of benefit. It doesn't cost anything.
So I can start, and then Jennifer, if you want to weigh in on this as well. It's actually closer to 3.5 million. 1.1, 300, and then 2 million at the
Oh, I missed
bottom. So it's a significant reduction in the total cost, which means it's a reduction in the premium. So to the extent that it reduces the premium, and we'll discuss a little bit more later how the premium is divided between the employer and the employee. But suffice it to say that on the premium side, the employees are the big winner in this. As I said before, the Muni's participation is generally pretty fixed. There's only a small range of movement in the Muni's premium year to year, or, excuse me, inside any given year. There's a lot of potential movement related to the employee contribution. This will, is probably shared with the employee 80-20. Now that being said, to the extent that you're using a preferred brand on the pharmaceutical program, you're going to pay $15 more per prescription than you were before. So in some cases, employees, you know, the plan hits every employee a little bit differently in terms of how they utilize. But the driver in this was to reduce the overall expense of the plan, which reduces the individual premium for employer a little, employee a lot.
Thank you, Mr. Abbott. Thank you, Mr. Wellington. Mr. Trainee.
Mr. Abbott, getting back to where we've got people that are married to somebody that's in the military, their military insurance covers the worker and spouse, we save money by doing that? For example, my wife, because I'm retired military, she never uses city because I work, I'm just wondering, are we taking care of that way?
So you
I've
want
got
to
to school
explain the
to do this
opt-out
years on
process?
that.
So, we do have an opt-out option for those people just in your specific situation. And, the employee then gets a stipend, if you will, it's $350 a month for opting out.
How many people are doing that?
I think there's 400,
400?
about 300.
Okay.
And it's a significant savings to the muni. So instead of paying $2,000 a month, $1,800 a month, something like that, for the employee share, we give the employee $350 instead.
Thank you.
Thank you. That happened a few years ago. Thank you, Mr. Trainor. Please continue.
So, Mr. Abbott noted, we were gonna talk a little bit about the split of the employee versus the employer contribution. And you'll see on the far left, the 2016. So that currently is for, and we have different bargaining agreements, but for the non-reps, basically, the municipality currently contributes 94.5%. So the employee has 5.5%. And in 2017, if we make no changes to the plan whatsoever, the municipality's contribution would be 89%, and the rest would be borne by the employee.
And we'll show you what that means in dollars
In just a moment.
here in a few seconds, but just in terms of percentages, the way the CBAs are written is the municipality's contribution is, the rate of growth in that contribution year to year is capped at medical CPI, which is
It's about 3.6% now.
3.6%. So by contract, our contribution, the employer contribution, can't go up more than 3.5%. That means that the balance, whatever that is necessary then to fully fund the plan, would have to come from the employee. And so what that second bar or column shows you is what it would be if we set the premiums where they need to be for 2017, and we didn't make either of the adjustments that we're proposing to make. One of which is the plan change that we just described. So if that changed, and we'll show you what that means in dollars here in a few minutes, but you can see that that would pretty significantly change the balance between employer and employee in 2017 from what was there in 2016. And a small percentage change in the total premium, if you're only paying 5% now, and you start paying 11%, that's a big change in your individual contribution on a monthly basis. So it's not big in terms of the percentage of the total premium, but it's big in terms of dollars per paycheck or dollars per month for muni employees.
Thank you, Mr. Abbott. Mr. Evans?
Just so I get the numbers right, because Ms. Penny used a number that didn't seem to correspond to what I'm seeing. For the 2017 original, if no changes are made, the MOA contribution would be approximately 92%, or 91% according to this. Is that right? It's over 90, looks like.
It's about 93 plus.
And currently, in 2016, it's around 97?
Oh, I'm sorry, 2016 is 93. Yeah.
2016 is 94.6 for the group that I'm looking at,
Right.
which is non-reps, IBEW, and Teamsters. When you look at the three different bargaining agreements, or the three different groups with different bargaining agreements, you meld it together to get this 94%.
Okay, that's what we're looking at. Okay, thank you.
Thank you, Mr. Evans. Ms. Penny, please continue.
So, these numbers are pretty shocking. If we make no, if we make no plan design changes and nothing else happens to our plan, we would need almost 17% increase into our healthcare plan. That's $43 million, $43.1 million. If we make the benefit plan changes, it gets that renewal down to 10%, a little over 10%, which is $40.9 million. If we are able to utilize the subsidy, it gets that renewal down to 6% or $39.5 million. The MO, and as Mr. Abbott mentioned, remember that the municipality's contribution is capped for the different bargaining agreements. So with the MOA's contribution to this, or the increase to the MOA would be 8.8% with no with no changes, right at 5% for if we make the benefit changes, and then a little over 3% if both things happen.
Mr. Evans?
I may have missed it before, but I've seen it on the last two charts, this $2 million subsidy. Did you guys?
We're getting
discuss-
there.
We're getting there. I'm trying to tee it up for you. I'm teeing
Trying
it
to
up for
tell
the
you in
mayor.
advance what a great idea it is. How we
You
doing?
can find this in the-
I need to find some.
So far, so good.
So these are the percentages, if, for the employees.
And just for the sake of clarity, and I've forgotten sort of our audience here, you guys are in the top category. I believe the assembly is treated like execs and
Non-reps.
non-reps.
Yes.
So, to the extent that you all are parts of the muni plan, and I think most of you are at least eligible to be, you're.
Let's follow up with that, okay? We're not part of the municipality's medical plan.
Never have
No,
been.
never have been.
I thought that change was made by salary and emoluments.
Here's what it
We
is,
should look
just
into that.
to educate folks. Well, I can tell you that it's not.
Yeah, I thought we did the annual
Every
payroll.
paycheck, we get $250 to use towards medical if we want. But it's our choice. So we're not in,
I apologize.
well, it's okay, I just wanted to correct that.
No, good correction.
Thank you.
Sorry about that.
That's okay, please continue.
So it's just us chickens.
Just you.
Right, that you're talking
Welcome,
about.
Thank you. Please continue.
So you can see if both things happen, and that's the $2 million subsidy and the change to the benefit structure, for that top tier, the renewal increase to the employee would be 7.5%. Today, it's 5.5%. So the change in dollars is $51.36 per month. These are all per month. And what I'd also like to point out, on the HSA plan, there wouldn't be a change to the there wouldn't be a change to the there is no employee contribution on the HSA plan.
And there would continue to be no contribution for the high deductible plan.
And in addition to that, the municipality's contribution on the HSA, the excess from the premium to the contribution goes into a health savings account or a flexible spending account for the member.
So this gives you an idea of the likely impact of the administration's recommendation, a portion of which requires assembly approval, on the individual employees. So if an employee has one of the two sort of, I'll call them standard plans, either the $500 or the $1,000 deductibles, they're going to see their personal contribution go up between $45 and $90 a month, depending on which of those plans they choose and which bargaining unit they're a member of. So those are big increases in
we have that data if you're interested in it over what they're currently paying. But you're looking at 30, 40% or more on the employee's contribution.
Mr. Dunbar?
I think you already answered this, but just to reiterate, these are changes we can make without having to renegotiate any of these agreements, is that correct?
That's correct. We are not proposing to renegotiate CBAs in this. This is the implementation of those CBAs.
Mr. Dunbar, please continue.
This graph shows us the orange line, if you will, are the premiums per employee per month that have gone into the 603 fund. The blue line are the net plan costs per employee per month. So you can see in some years we performed well and we were overfunded, and then we were underfunded, and we made adjustments back and forth, and that's why we wanted to show you this graph, especially from 2014 to 2015. You can see that the plan costs went up significantly, and yet the premiums stay about the same. Do you have any questions?
No.
So just a point on this. The reason that we're able to address that is because the 603 fund has historically had reserves in it. So the net effect of the last 11 years of activity in the 603 fund meant that we started 2016 with about $5 million, I think, of reserves in the 603 fund. The premium that we put in place for 2016 anticipated using $3 million of those reserves. Our target was about a $2 million landing spot. What has happened in 2016, year to date, and our projections for how we're going to finish the year assume that almost all of that $2 million reserve will be necessary to fund the program. In other words, the plan is going to spend more than it was expected to spend in 2016. So we're going to end the year there's still a lot of the year left, so it's hard to predict this precisely, but we're going to end the year $300,000, $400,000, $500,000 left in reserves. That is too low, we believe, in terms of how we manage this program going forward. So one of our objectives is to get the reserves back where they belong, back where we believe they should be, so that when we finish 2017, we have reserves of approximately $2 million. And our recommendation for how to do that is going to be described here shortly. But we're going to recommend that we make an infusion of $2 million to the plan in 2016, so that it lands at the end of 2016 $2 to $2.5 million to the good, and that would then be the starting point for the calculation of the 2017 premiums, and that's what we've been describing to you so far here. So that, I think, takes us to the next slide. So I just wanted to make sure you understood. We've in some years we have to grow reserves. In some years we're able to spend them. We've been spending them for a couple of years, and now we're not in that mode anymore. We had hoped that in 2017 we could just be flat and only collect as much money as we intended to spend. Unfortunately, 2016 looks like it's not going to be a great year. Not as bad as 2015, but still not good. And as a result, we need to improve the reserve position to sort of give us an appropriate amount of operating room for the plan in 2017.
Thank you, Mr. Abbott. Please continue.
So we've kind of given you all the information of how we got to 16.9% utilization, large claims, et cetera. And we have a two-step process to get us to a 6% rate increase. And we talked about the benefit modifications that we would like to make to the plan to offset some of that down to 10%. And then, as Mike mentioned, a $2 million infusion into the fund, into the 603 fund, which would impact the MOA and also the premium for the individual employee. And as an example, and I just picked a random range, random employee, not anyone specific, but a range 12, a step 3 makes approximately, it makes $51,500 a year. If they're currently on the $500 plan, the deductible plan, currently their the employee's contribution is $105 a month, or $1,200, $1,300 a year. The 10.2% increase would increase that to $240 a month contribution from the employee, or $2,880 a year. And then if we get to the 6%, if we're able to get to that 6% rate increase, it would take that employee's contribution to $157 a month, or $1,800 a year.
Mr. Training.
I appreciate the $2 million loan, but where is it coming from, Mr. Abbott?
601 fund, the risk management, workers' comp, self-insurance program, which is currently funded with around $20 million. It is funded so that it can cover, I'll call it anticipated, because that's the term the auditors use, anticipated expenses associated with the workers' comp program. However, that's a very speculative calculation. I think the auditors and their actuaries would agree with that. And it is not payable in the near future. That is the permanent, or the long-term liability associated with incurred but not yet reported claims. So the CFO's office and others, myself included, agree that a short-term loan for $2 million from that fund can be comfortably tolerated. It'll still remain an asset of the fund. They'll have an IOU, or they'll have a credit against their program, but they will not have access to the cash, and they won't need it for decades in all likelihood. And by then, we'll have either repaid the loan over, I think, a 4 or 5 year period, which is what's programmed, or it'll be defeased, paid off early because of improvements we expect to make in our health plan over the next 2 years.
Are we then gonna have a written program to pay the money back?
Yep, and that is in the assembly document that is being introduced as we speak, and will be available for introduction by the assembly on the 18th of October, public hearing and action on the 1st of November, and I believe it sets a 4 or 5 year payback. It's in the document, I apologize, I don't remember it. 5 years? 5 year payback. And it is our intent to pay it off early, but if not, then the debt service, the P&I for that, would be paid back as a 603 expense over those 5 years.
Thank you, Mr. Abbott.
Thank you, Mr. Chairman. Mr. Mayor, did you want to say something?
I just want to point out that, that if we revert to the mean, we've historically had to pay to the 603 fund, take these last 2 years, factoring them in. If we come in and I believe 98% is what we normally do, based on those savings alone, without any other programmatic change, we can pay this loan back in fairly short order. And I think, given where interest rates are today, given the fact that I think people look at those numbers, those increases, even with the loan involved, you're going to see a move towards the HSAs. And I will also underscore that it's my intention, and I hope that I can get your assistance in doing this, we have got to change how we deliver healthcare, because ultimately this is not a sustainable model of delivering healthcare. We're going to talk about some of those opportunities moving ahead, but this is, because of the situation we're in, we have an opportunity for some meaningful change.
Thank you, Mr. Mayor. So my question is, so what's the interest rate?
It will be the foregone I don't, I wanna make sure I get that right, so.
It's about
I will-
2.4%.
Thank you, Mr. Mayor.
And for clarity's sake, I misspoke, it's the 602 fund that is the risk management fund.
Right.
601 fund is the fleet fund. Lance was right, I was wrong.
That's okay.
I get the numbers screwed up all the time, sorry.
Okay, thank you. Ms. Dombowski has a question, and she asked me to ask it. What do the numbers look like if we went to a 70-30 split? That's from Ms. Dombowski. And if you need to get back to us, that's fine.
We would definitely
have to-
need to go back.
Okay, Ms. Dombowski, if you're there, are you there, Ms. Dombowski?
I am, I just pulled over.
Okay, well, be careful, please. But anyway, they're gonna have to get back to us with that question, okay?
Yeah, that's fine.
Thank you. Please, Mr. Trainee, did you have a comment?
Mr. Abbott, can we change the opt-out from 300 to 200? Reduce the amount we're giving them to opt out to some number that's viable? Or is 300 some magic number to opt out?
It is, yes.
I don't know. Will, I
Could you look at it for us?
Yeah.
It has to be an amount to encourage the employee to actually.
I know, but I'm trying to figure out
It
what's-
ends up saving the municipality quite.
So, we'll get you that information.
Thank you.
Thank you. Please continue, Ms. Manning.
So as the mayor mentioned, there's some things that we, will be doing moving forward. In addition to try and help bend this cost curve that we know that the cost of healthcare in Alaska is not sustainable the way it is. So we want to look at wellness initiatives. You may remember, those of you who have been here for a while may remember there used to be a wellness program and it was dropped several years ago. So we're exploring new opportunities with that. We're also looking at maybe some value-based medical provider contracts, different from fee-for-service. Excuse me. We are also maybe looking at some targeted campaigns for diabetes, pre-diabetics, some pharmacy wellness tools that we may have access to, a wellness platform, computer-based platform. And then we'll be doing a lot more communication with our employees on preventive care and checks and things like that. And then we also are talking with a company in town called AIM. And AIM, it's Alaska Innovative Medicine. They are partnering with Primera currently and do assist in case management and a more targeted case management than just what Primera does today. For the financial stability of the 603 fund, it makes more sense to me to have small incremental increases annually as opposed to having rate holds for 3 or 4 years and then all of a sudden we get a 17% rate increase. It's much more tolerable to have a 3 or 5% every year. We're, one of the things that the mayor has tasked us with is to look at different pooling alternatives. So pooling, joining with, for instance, the Anchorage School District, perhaps joining with them and having a much larger pool.
On that front, Madam Chair, we're talking to the state as well. I mean, this is a cost-saving measure where I think both the municipality and the state would benefit if we expanded the size of our pools and were able to aggregate some of our risk. Aggregate and therefore minimize.
Thank you, Mr.
It's not
Mayor.
cumulative.
Yeah. Please continue.
And then finally, we're also looking at some regulatory advocacy. Earlier, I mentioned the 80th percentile rule. I'm part of the Alaska Association of Health Underwriters, and that organization is lobbying the state to try and get that regulation changed and have out-of-network reimbursement to providers, a percent of Medicare, whatever that percent may be, but to get rid of that 80th percentile. And also, in addition to that, or separate from that, is a balanced billing advocacy, so that currently, for those non-contracted providers, the provider can balance bill you for anything above what the insurance doesn't pay up to their charges. So we want to try and get some kind of legislation that says you can't balance bill.
Mr. Weddleton?
Just so you said, you're lobbying to change this 80th percentile, but I thought that does not apply to us.
It doesn't apply to us, but it applies to a lot, like us, a lot of self-insurers just have always done the 80th percentile rule. But we don't have to, you're right.
It becomes the default.
Right, it becomes the default, yes, sir.
Thank you, Mr. Weddleton. Mr. Dunbar?
Two quick questions. So for the out-of-network, for the 80th percentile rule, are we thinking about adding that to our legislative request? Is that going to be part of the municipality's request, or is it going to be a separate, you mentioned a different organization doing that advocacy work?
Actually, this is something, okay, Madam Chair,
Sure.
this is something the governor could just do by himself.
Okay.
The legislature doesn't need to act. This requires the governor to affect some change.
My second question is, could you try again on that balance billing, because I didn't understand what you said.
Sure. So,
Apologize.
if for a non-contracted provider, they charge $100. The 80th percentile, let's say, is $80. So Primera or whomever is gonna pay in the 80th percentile of $80. That's the usual and customary, if you will. So they're gonna pay $64. The provider, who's non-contracted, can now balance bill the patient from 64 up to the 100. So instead of just having a $16 bill, co-insurance amount, you're now $36 that the provider can collect from the member.
Thank you, Mr. Dunbar. Please continue.
That's all I have.
All right, thank you very much. I just have one comment. Thank you for the presentation, and we have to do what we have to do. But I'm really happy we've been talking about it, reinstating the wellness program, because that's one of the Let's Move All-Star strategies that we're trying to, our goal we're trying to meet. So let's talk more about it offline, okay?
Sure.
Thank you. Any other, Mr. Peterson?
Thank you, Madam Chair. And Mr. Abbott, you said, maybe 20 or so minutes ago that the employees will be getting a better deal with the new plan. Are we hoping that they're actually going to believe they're getting a better deal?
No, I meant that they're going to get a less expensive plan than what they would have had otherwise. And depending on how they personally utilize the plan, the majority of members, I think 90% of the members will see more benefit from the premium reduction than they will from the extra cost that they might incur through the changes in the plan. So 10% won't, and I mean, that's the converse of it. But our calculations indicate that 90% of our employees that are in the system will be benefited by reducing the premiums, even though that means that the benefits are less as well.
Thank you, Mr. Peterson. Mr. Weddleton?
Okay, I just wanted to back up a little bit. I think you said we have kind of a stop loss of $500,000 per person.
Individual.
Is there a cap on total plan? So we're vulnerable to crazy stuff happens. It could be millions of dollars.
Well, the reinsurance kicks in at $500,000. So then the reinsurance takes that.
But
life
per
loss.
person, right?
Right.
So if 100 people came in super high, we have on or whatever, it's on that.
We would have 100 times 500,000.
Right, okay.
The reinsurance carrier would have the risk above 500,000.
Thank you, Mr. Weddleton. Just to follow up sort of on what Mr. Weddleton was talking about, isn't there a lifetime limit per employee?
Not anymore.
Not anymore?
Thanks.
Okay. That's interesting to know.
The Affordable Care Act, there is no lifetime maximum any longer.
Thank you. Anything else, Mr. Dunbar?
Well, just going off of what John reminded me of what I wanted to ask. If we have that reinsurance above 500,000, these black swans now are above 500,000. Does that mean it's actually more affordable for the municipality if they break that 500? I guess we pay up to 500 regardless, is what you're saying.
Correct.
But
And every year, right? So it's over $500,000 for 7 years, you're paying half of those 7 years.
so when you show that 13% of people that were above 500,000, that means there's been many more people with those kind of versus people with unusually expensive problems because they're hit once they hit 500,000, the reinsurer kicks in anyway. Is that right?
I don't think I understood that.
I don't think I did either.
I actually am sorry, I'm Sheree Hendricks, and, that 13% represents 3 individuals. So, no, that's,
So I don't understand how our reinsurance works then. Why aren't they each costing us 500,000? Why are they costing us much more than 500,000?
Well, so they're costing you, they are only costing you 500,000 per calendar year,
Okay.
right? But if you have 10, to Mike's point, if you have 10 people, then you're gonna pay 500,000 times 10, and it's unusual even to have $500,000 in claims. I mean, that is in and of itself, and then to have as many as you did in one time period is unusual. And then to further complicate it, some of the members of the plan who had unusual expenses straddled 2 calendar years, so you had $500,000 in 2015 and then another $500,000 in 2016.
I think we should go forward. I don't see any other questions. Thank you very much for the presentation. Work session adjourned.